evening. My name is Francois Mach. I'm head of the cardiology department here in Geneva, Switzerland. And I'm very pleased and honored to be part of this workshop on dyslipidemia for the Saudi doctors and Saudi administration in health. I would like to thank also the organizer, of course, but also all the technique. It's now a couple of minutes that we are looking how to be able to present this from my office here in Geneva. And I would just need from the chat link from this wonderful person who helped us that everything is okay and that you can hear me loud and clear, and that you may have my first slide now. Mention good, so we can, I will have to look at my slide on my screen. You should have the first one, which is the title, Management of Hyperlipidemia or Dyslipidemia after acute coronary syndromes. We will focus mainly on these patients. Next slide, please. Second slide, you should have that I don't have any financial conflict of interest for these kinds of conferences or also advisory boards that I did or I'm still doing. All the salary that I could receive goes to a foundation, which is named GICOR Foundation. You can see the name on the upper right of this slide. And this foundation is completely linked to the Geneva University Hospital and help us with this money to develop a cardiovascular program for patients, for nurses, and all the contract that we can pass via pharmaceutical companies go through our legal authority in our department. Next slide, please. You should see the slide with lipoproteins. There are many different lipoproteins that differ in diameter, in density. We will talk only today on LDL particle. We will not talk on Lp(a), or just for now, for 2 seconds, please measure Lp(a) in any patients or even person at least once, because Lp(a) can be a risk modifier if Lp(a) is high or elevated. It's only due to genetics. And even though we don't have tools today to reduce, this treatment will come in 2 to 3 years from now. Many studies are ongoing. But still, if a patient has a high Lp(a), this is from birth due to genetics, and he or she will have an increased risk due to that. And thus, all the other risk factors that we know how to modify, especially LDL, should be really at the target. Now we're going to go quickly to the next one, should be LDL cholesterol, is the main driver for atherosclerosis, and we have a lot of compelling line of evidence, and clearly now LDL cholesterol, when elevated, is causal to the development of atherothrombosis and the event linked to atherothrombosis, which are mainly acute myocardial infarction, acute coronary syndromes, due to the deposition of lesions in the coronary artery, or strokes, ischemic strokes, due to the deposition of atherothrombotic lesions within carotid arteries in the neck, or also within cerebral arteries in the brain. Next slide. Time exposure to LDL. As for tobacco smoking, it's easy to remember. The longer you have cholesterol high, the longer you have a high LDL cholesterol in your circulating arteries in your blood, the higher is the risk. It's only a risk. As for tobacco smoking, you will find persons who smoke for many years and don't have any disease due to tobacco, but it's clearly a risk. The higher you smoke, the higher cholesterol for the higher time, the long time, the higher the risk of having one of these cardiovascular events due to atherothrombotic lesions, acute coronary syndromes, we'll come back to this one, and or ischemic stroke. Next slide. History of LDL lowering trials. We have now for the last 20 or close to 30 years, next year will be 30 years, that we have lipid-lowering drugs starting with statins. Some of you may remember in 1994, the 4S trial. Then we have the more potent, more aggressive statin. We have studies comparing low efficacy statin to high intensity statin. Then in 2017 came the Jupiter trial. 2007 so came the Jupiter trial, which launched rosuvastatin in persons, not even patients. And then the big advantage and the big breakthrough came in 2016 with IMPROVE-IT, when we have ezetimibe on top of any kind of statin. And then in 2017 came the MABs, the monoclonal antibodies, with evolocumab, Fourier, and a year later in 2018, Odyssey trial with alirocumab. Next slide. Time exposure to low LDL cholesterol. In this busy slide, you can see in red the so-called pharmaceutical randomized controlled trial comparing a drug A to a placebo or to another drug, but neither, it's double-blind, neither the patient, neither the investigators are aware of the result. The trials are very expensive, as you can imagine, and thus they last 4 to 5 years. But if you look after 5 years of all of these trials, if you can reduce with any kind of lipid-lowering drug, statins, ezetimibe, or the new alirocumab, if you lower by 1.6 millimole, which is really feasible with these three classes of drugs, if you lower by 1.6 for 5 years, the relative risk reduction of these persons will be close to 30%. Now, for the same magnitude of LDL lowering, 1.6, but if you increase this time to 10 to 20 years, this is feasible with so-called prospective cohort. So these are not randomized controlled trials, but nevertheless, if for the same magnitude you can reduce LDL cholesterol from 5 to 10 to 12 years, then the relative risk is close to 50%. And I hope we will see the fact that by genetics, I told you that you can have dyslipidemia due to genetic mutation that then increase your LDL or your Lp(a). There are mutations that can decrease these LDL cholesterol from birth. And this is how PCSK9 MABs were discovered. And one day we can even imagine that the treatment will be to induce a mutation at a certain timing, 20, 30, 40 years, depending on your risk, to induce, to correct, or maybe even to induce a mutation. The message here is that if you can reduce by the same magnitude, 1.6, for 50 years, then the relative risk reduction will be close to 80%. So time exposure, the longer time with the higher cholesterol increase the risk, but also if you can reduce the lower cholesterol LDL reduction for the longer time, you will have the best reduction in cardiovascular event. And this is how the latest 2019 now ESC guidelines, together with the European Atherosclerosis Society, were built. And you may be aware of these guidelines. The big difference is that the item quality high or very high risk, almost all diabetic patients or even patients with chronic kidney disease will be classified high or very high, and these categories need to have now a goal below 1.8 or 70 milligram deciliter and 55% from baseline, which is without lipid-lowering therapy. And for the very high risk, it's even harder, it's 50%, and to reach 1.4 or 55 milligram deciliter. These guidelines were somehow very well accepted. I just went to these metrics a couple of days ago. As you can see, the total view on the web is more than 1 million. The page viewer is close to 800,000, and the PDF download is close to 300,000. And if you look below, the total already cited, the citation of this manuscript is close to 4,000. So in another 4,000 journals or papers or manuscripts, these guidelines were now cited. To help doctors and patients, you have this table on the guidelines that if you use a high-intensity statin, you can do already half of the job for the very high-risk patient. 50% will be achieved. If this is not enough to reach the goal of below 70 or 55 milligram deciliter, you can add ezetimibe, which is very cheap, without side effects, and you can reach a lot of more patients can reach these new targets and goals. If this is not enough, and for some categories, and you will see new guidelines, especially from your country, launched very recently, that for high or extreme risk patients, we may need to add immediately, at the time of the event, on top of a statin, and maybe ezetimibe, depending on the level of LDL at the start. We may need to add the PCSK9 monoclonal antibodies such as alirocumab or evolocumab. The next slide is the PCSK9 maps and cardiovascular events. You have here the two main landmark trials, 2017, the Fourier trial, which included more than 27,000 patients, very high-risk patients. And next year, the year after, 2018, the Odyssey outcome trials with something like 18,000 patients, also very high-risk patients. They all had an acute coronary syndrome quite recently, and patients would be able to be included if the acute coronary syndrome was just after 3 months. If you look at the safety, next slide, safety and efficacy and safety in the Fourier trial, due to the number of patients included, you can see on the bottom right that had during the trial, which lasted only, we can say only 3 years, or even just less than 3 years, more than 1,000 patients had an LDL cholesterol below 0.4 millimole per liter. And just by this, they have, if you look at the bottom left, they had a lower risk without any side effects. And this is really important to mention to our colleagues and also to our patients, that if you lower LDL in the blood with these kinds of agents, at least for this study that lasts only 2.5 years, but you will see more data in the next slides, there is absolutely no fears regarding increasing some side effects. Next slide, and this is exactly what I'm mentioning. The Fourier trial had an extension, the so-called Fourier-Ole trial. Extension, open label. You will see in a minute what I mean by open label. This study was presented last year at the ESC annual meeting in Barcelona on August 29 and immediately published in Circulation. What the investigator did, next slide, study schema. They took random from the evolocumab group in the Fourier that was completely matching with the placebo double-blind in the Fourier. They took 3,000 patients in each group. Same numbers of men, women, diabetic, and all cardiovascular risk factors. They took 3,000 in one group, 3,000 in the other group. Total is 6,000 patients that were all placed on an open label with evolocumab. Why? Because it would be not ethical to continue this matching placebo. Already mentioned, Fourier was a fantastic positive trial, so you cannot let the patient in the placebo continue with a higher risk. So that's somehow something we have. It's an open label. All the patients now will be placed with evolocumab. They all come from the Fourier trial. And the extension is for more than 5 years. So you add 5 years from the open to the 2.2 years of Fourier. This is at least 7 years. Some of the patients had a total of 9 years. This is really critical for not only efficacy, but also for safety. Next slide. Effect on LDL from the Fourier-Ole. As expected, if you see the patient, the 3,000 that were on the placebo in the main landmark Fourier trial, they all went down to be close and to be as with the other that were on the benefit of evolocumab in the Fourier primary trial. And second message, also very important, there is absolutely no what we call tachyphylaxia. All the person from the beginning, from 2 and 2.2 years, and after 3, 4, 5, 6, 7, 8, and even 9 years, all the patients on evolocumab kept an LDL very, very low, close to 0.75 millimole per liter, which is 30 milligram per deciliter. So you can tell your patient as soon as they start the injections, twice a month or once a month, depending on the dose they use and how many pencil they will use per month, their cholesterol will be lower, and this will be kept as continuing their treatment. Now, regarding the result, again, this is an open label extension. It really mentioned to us that you can reduce cardiovascular death, MI, stroke, unstable angina, and the need to coronary revascularization if you treat the patient as soon as possible. As you can see here, they were all, during this 5 years treatment, they were all on evolocumab with a very low cholesterol. Nevertheless, the one who came from the matching placebo from the Fourier trial still had an increased risk that tend to reduce, and normally if you follow these two curves on a longer time, they will be close together. But the message there is that if you have to treat your patient as soon as possible. Same for key secondary endpoint, cardiovascular death, MI, or stroke. If you look at cardiovascular death, it's exactly the same. Now, you may remember that in the Fourier trial, there was no difference in cardiovascular death after 2.5 years. But then it seems that the curve diverges because the fact that the person in the first trial, in the first Fourier trial, matching placebo, the one with a high LDL will have so-called unstable plaque. You will see some data in a minute that may translate to a cardiovascular event later on, even though they were placed on the same drugs. So the message there is clearly that if you have a high or very high risk patients, and these were both the case in Fourier and in Odyssey, they have to be placed as soon as possible with as low as possible LDL. And this is only reachable with one of the two MABs, at least in the Fourier OLE. It has been proved to be efficacious and safe, you will see in a minute, in a few slides, with evolocumab. The next slide is a busy slide. We will be quickly on this. It's the MACE by year of study during Fourier OLE. It seems that the legacy from the first Fourier landmark trial will be somehow reimbursed. The lag will be reimbursed with the legacy. Again, you need to treat as soon as possible. Otherwise, if you tell the patient that we can wait, if they are at very high risk, if you tell them we can wait and delay the start of the treatment, they may still have a risk of an atherothrombotic event, which could be dramatic because we are talking about MI, about stroke, or even cardiovascular death. The next slide is safety during Fourier OLE trial. We were able to look with these 6,000 patients that were followed at least for 7 years with this evolocumab, with a very, very low LDL cholesterol. 7 years, and even for some patients, 8 or 9. Look at data, busy slides, serious adverse events, absolutely no fears that if you continue with a very low LDL, the patient will have more serious adverse events, even the contrary. Injection site reaction, absolutely nothing, as you can see here, even for the contrary. Same for drug-related allergic reaction, muscle-related event, absolute, and something which is we don't understand. Again, it's an open label, but the new onset of diabetes seems to be going low. We have to do still continue some of the mathematics, but clearly you can tell your patients, contrario things, that with evolocumab, on a long term, not even you are protected for cardiovascular events such as cardiovascular death, but you are also protected from the risk of developing a new onset of diabetes. And again, absolutely no fears to have increasing hemorrhagic stroke events. These are very, very marginal numbers, as you can see here, not increasing with exposure to evolocumab for more than 7 years. Now, you're going to say this is a trials with a drug company trial, Fourier, Ole, or Odyssey. You can go if you are not completely convinced, but you will be with the next two slides. This is LDL, should we go lower after ACS? A fantastic paper from Mother Nature, your treatment, my treatment. This is in Sweden. Look at 40,000 patients after an MRI. And they look their cholesterol level at year 0, 3, 6, and 9 years. We don't care how you reduce cholesterol, statin, ezetimibe, or one of the MABs, evolocumab. What you can tell, next slide, these are the results. Should we go lower after ACS? In the middle, you can tell the patients that, yes, they will be more alive or less death. I'm sorry about this formulation, but if they want to be more alive, they need to have their cholesterol here in purple as low as. If I can reduce your cholesterol below 1.8, this is the delta. If I reduce by 1.8 or even more, this is mother life, 3, 6, 9 years. With statin, ABC, ezetimibe, or the MABs, then you'll have less cardiovascular events, such as dying from cardiovascular events. Now, we come to close to the end. How does it work? This is the next slide about efficacy after recent MI, together with the fantastic fellows that went back after his fellowship of 2 years in the TIMI group in the Mach Sabatin team, Baris Genser. We were able to somehow prove that in the Fourier trial, the patient who had a recent MI on the left means within a year. In Fourier, you were able to include patients with MI older, 2 years, 3 years, 4 years. But on this slide, you can see that the higher risk patients, the higher the risk if the MI was recent. And not surprisingly, for these patients that had a recent MI, the reduction of the risk was even higher if you treat them with a very low LDL, such as with evolocumab. And this may go through the lesions. The Glakov trials look at the progression of atherosclerosis volume, and this way compared to placebo. It will not be ethical now. You look at lesions in the coronary artery. We can go to the coronary imaging study on the next slide. You see here the coronary angiogram and the IVUS, the intracoronary ultrasound images. You can see the plaque volume. You do this at time and after 1 or 2 years, and the same doctors does the procedure on the same artery, and you can calculate the volume because you have a lot of images, and you can calculate the volume. In the Glakov study, next slide, you have here the result of evolocumab reducing only 1%, but this is only after a year, but still 1% left of the volume of the atheroma that is in your coronary artery. So you can tell the patients that you reduce their risk probably by reducing the volume of their coronary artery. Next slide, this is the Huygens on top right, the Huygens trial, also using evolocumab. They were able to really describe the fact that not only you reduce the volume of the plaque, but you also improve the quality of these plaques. There will still be some plaques left, even after use. But what you need for these resting plaques is that they are not prone to rupture, which will cause events. In the brain, the heart, you need these plaques that are probably less big in volume. They also need to have the best quality. And this has been proven in the Huygens trial. If you reduce LDL very low with evolocumab, you have a less volume. Okay, this was confirmed. But also these plaques were less prone to rupture because the quality of the plaque was better. This is the recent paper from the Huygens. This slide shows you the JACC publication. And nicely, this was on the next slide completely confirmed in this JAMA paper. We did this in Europe, mainly in Switzerland, with some colleagues from Bern, Lorenz Reber, with the other treatment, alirocumab. Exactly the same result. When you lower LDL, you lower plaque volume and you increase the plaque quality. I was able to place this. This is my slide on atherosclerotic plaque regression in serial IVUS, intracoronary imaging studies, statins, of course, but the lower you can reduce cholesterol here on, it is mentioned 1, 2, 3 millimole, and you can see this dot red line, the lower you can reduce, and from something below 2 and close to 1 millimole of regression of LDL on treatment. This is achieved LDL. If you have an LDL at 1, achieved LDL at 1 millimole per liter, clearly you can reduce the change in plaque atherosclerotic volume. And here the two studies, Huygens with evolocumab and the Pacman with alirocumab are placed compared to the placebo. Now we come to the ACS patients. We were very fortunate to do the EVOPAX study that was only in Switzerland with 300 patients that received at the time of an ACS for the first time, first in men at the time of an ACS, they received in the cath lab either placebo, double blind, or evolocumab. And this injection was, the treatment was reproduced after 4 weeks and after 8 weeks. It was a feasibility safety study to look how we can reduce safely LDL with this agent at the time of an ACS. As you can see on the right side of this scheme, cholesterol was very lowered, achieved after 4 weeks. So only one treatment with evolocumab achieved 0.79, exactly the same number than in Fourier, compared to placebo. Placebo is atorvastatin, of course. They all had an acute STEMI or non-STEMI. And this was also statistically significant, the reduction with atorvastatin, but clearly a huge gap between the one on atorvastatin and evolocumab, and it was sustained after 8 weeks. What this graph doesn't show you is that at 8 weeks, 90% of the patients with atorva and evolocumab were at the new guidelines, below 50% and below 55 milligram deciliter, compared to only 10% in the group of patients with atorvastatin and placebo. So it's really efficacious and it's really safe to inject this at the time of ACS. At the same time, in the US, the same compound were tested for the same purpose. They did something a bit different. You can see on the right panel, this is the slide called Early LDL Reduction with evolocumab, the EVAX study. They look day after day. And you can see here that after 1 day, after 3 days, after 4 to 6, 7 days, already at day 5 or 6, you reach the LDL as low as possible. You inject with evolocumab. So clearly you can say it is very safe. And yes, my patient on top of statin, which is still recommended, if you received evolocumab, and this is the only one tested on this setting, if you receive 140 milligrams subcutaneous of evolocumab, the LDL cholesterol will be close to 0.8 millimole within a couple of days. And this is really efficacious and completely safe. Next slide is the, and I'm very proud about the next slides. First time I'm showing this one, guidelines, the 2020 Saudi guidelines for the management of dyslipidemia. Together we were asked, and thank Alberico Catapano and Baris Ganser to help fantastic persons that are named also here, and I will say hi if there are some of them, especially the last author Adel, if he's online. It was a great pleasure to participate to these Saudi guidelines. What is new on these guidelines? And this is on the next slide, new in ACS dyslipidemia management. In my knowledge, this is the first time that in a country, national guideline placed that to add ezetimibe or a PCSK9 monoclonal antibody in combination. So you can use which one you want, but the only one tested, as I just mentioned, in EVOPAX, is evolocumab. So now, as mentioned here, a statin therapy that include high-intensity agent in combination with ezetimibe or PCSK9. And again, if you want to be as low as possible, very safely, you add to a statin on the day or the next day of an SES, evolocumab, to all your patients. There is also a recommendation to use triple therapy, which is statin, ezetimibe, and one of the PCSK9 if the patient is not reaching the new goals, which is below 1 millimole after any kind of acute coronary syndrome. So this is something also new, and I'm pretty sure, this is my guess, personal guess, that many other national guidelines will endorse this one to add one of the monoclonals that is Aliro or evolocumab. But again, only evolocumab has been tested on this setting to all acute coronary syndromes patient, and hopefully the ESC will do it in the next lipid guidelines. I will end by the fact that yes, there are some studies ongoing, especially or only with evolocumab. This is the Amundsen study that is done by Gilles Montalesco, a good friend in Paris. Geneva is participating to this study, which is also an open label. We will have close to 1,500 patients, and we are going very well with the enrollment. They all have STEMI or non-STEMI. They all need to be injected in the cath lab on the table just before the balloon. Could be balloon with stent or only drug-eluting balloon, but it's only for the patient who will benefit from a balloon angioplasty. They receive either evolocumab, or they will have the best standard optimal medical treatment. And we will see it's EVOPAX on a long term to see if the LDL is still maintained after a year, and we will have as a secondary endpoint also, but due to the number of patients, we may not reach statistical significance. The next slide is LDL, should we go lower after ACS? Amgen is doing a study nowadays, and this is mainly in the United States of America and Brazil. This is the Evolve MI. After all the patients will, this is double blind, more than 4,000 or 5,000 patients that are included these days. After ACS, could be non-STEMI patient will receive either placebo and statin, of course, ezetimibe, or evolocumab on top of course, statin and or ezetimibe. And we hope that this study should be presented in 3 to 4 years from now. So we go to the end. This is close to the end. This slide is entitled The Modern Concept of Lipid-Lowering Strategies to Reduce Cardiovascular Disease. We should think to measure lipid profile as soon as possible. In the guidelines, recent ESC prevention guidelines, we mentioned 40 years old for everybody. And this is also to screen for familial hypercholesterolemia. This is so-called cascade screening. When you do your lipid profile, don't forget to do at least once Lp(a). We should not repeat Lp(a). Again, it's only increased with genetics. And if it's normal, never do it again. When you have a patient, and especially with very high risk or extreme risk, we should not be afraid to aggressively lower LDL, and this is in the blood only. We lower LDL in the blood, and with the evolocumab extension, the open label extension study of Fourier, the Fourier-Olé, with evolocumab, all the patients were close to 0.7 to 0.8 millimole for 8 to 9 years. No side effect. So you have to be sure that the patient will be at the new targets, 50% reduction in below 55 milligram deciliter. And for most, if not all these patients, it's a statin plus either ezetimibe, and why not? This is again cheap and no side effect, and efficacious. Bempedoic acid could be also added. I placed this here because of the recent trial that came, the clear outcome trial, and the use of PCSK9 monoclonal that have been clearly tested and shown to be statistically significant. And again, in your new Saudi guidelines, there is now the need to give statin and immediately a PCSK9 monoclonal antibody. This is from my mentor, Peter Libby. It's not completely updated because it went out last year. The paper in the European Heart Journal, together with Lale from Ankara, Turkey. As you can see here, there is one mistake since now bempedoic acid has been proven, but we can use combination therapy. And as you can see on this slide, that a lot of our colleagues participated. We should now move. There is a double slide here, though I don't know which one you're seeing. If you see the first one, you have some colors, and for extremely high-risk patients, you can start statin, ezetimibe, and PCSK9 immediately. This is the Saudi way, the new guidelines. And we are doing this here, depending on, of course, of reimbursement. And if the patient is at a lower risk, you can start with statin, ezetimibe, and rapidly measure, if not place most of the time a PCSK9 to be sure that most of the patient, if not all the patient, will be at the guidelines. So the message, this is on the click on the same slide, should appear the conclusion that we place on this paper. Therefore, we should move away from high-intensity statin treatment and the wait and watch paradigm, and instead start treating immediately all very high and extremely high-risk patients with the combination therapy as the basic standard of care. And honestly, I think what has been proven is a high-intensity statin and one of the monoclonal antibody against PCSK9. And if you want to use the one best studied, is clearly evolocumab. So the lower, the better, and the lower for the lifelong. And I place this now, it's a new statement, lifelong. We have now, for more than 7 years of follow-up, patients with a very, very low LDL, thanks to statin and to evolocumab, with very low cardiovascular risk factor for future cardiovascular event, and very, very low, very reassuring safety issue. Now, there is still, this is the last slide, residual risk. Cholesterol, you have to mention. Inflammation, we know that if you target inflammation, you may reduce. We don't have good drugs. We only have been able to show that systematic anti-inflammatory, but you have to pay a price. Then you have the thrombotic risk, of course. Your patient may be at high risk of thrombotic events, thus they need antiplatelets and sometimes anticoagulation. Triglyceride is also a big issue. We were very disappointed with the prominent trial with fibrates. A lot of us think the fibrates is now not anymore a good drug to be given. There are big hopes for Lp(a), as I just mentioned, and we hope that some trials will come positive that reduce Lp(a), of course, in patients that have a high risk due to an increase, genetic increase Lp(a). And finally, also a lot of patients with diabetes should now benefit from the recently SGLT2 inhibitors and also the GLP-1 antagonist. And the last slide will be to thank all the audience, and I'll be delighted to answer questions. And thank you also for the great support from the techniques. Thank you.